All right, everyone. Thank you for joining this evening. We want to welcome Dr. Dan Davis, our shoulder and elbow surgeon at Rothman Orthopedics, who will be giving us our presentation this evening. Dr. Davis sees patients at our Bluebell, Bryn Mawr, Center City, and Willow Grove office locations. And just a couple of housekeeping items for this evening. We will take some time at the end to answer questions. Dr. Davis will. So please enter your questions in the Q&A box at the bottom of your screen. Please keep your questions as generic as possible, not too specific to your case. But I know that Dr. Davis will take time at the end to get those answered for you. So thanks everyone again for joining, and Dr. Davis, you could take it from here.
Great. Thanks, Natalie. So yeah, if you guys want to, as we go through this, put questions in the comment box, then we can go through them once we finish up. The talk itself won't take the full hour, so we can spend some time reviewing some questions. But I'll be talking about shoulder surgery recovery timeline. So kind of what to expect after shoulder surgery. It's a pretty broad topic, but a lot of times I end up talking about specific surgeries themselves or why you have surgery. And I thought it would be interesting to go into what the recovery from some different operations looks like, as that's a very common question that I do get. Give a little background on myself. My story, I originally am from Pennsylvania. I grew up in the northeast part of the state, outside of Wilkes-Barre. Um, my senior year, I actually moved away from there, and I spent a little bit of time in the Virgin Islands. That was for 1 year, graduated from high school there, and then I moved to the South for college. I went to Wake Forest for my undergrad, then even further south for graduate school and medical school. I was in New Orleans at Tulane. I then came back up to Pennsylvania, haven't left since. So I started my residency at Jefferson in 2011, stayed in my orthopedic residency for 5 years at Jefferson, and then an additional year at Jefferson and with the Rothman Institute for my fellowship in shoulder and elbow surgery. Then I've been fortunate enough to work at Rothman since then, and have been here ever since. A little bit about myself. So that's kind of my professional background. So obviously I'm an orthopedic surgeon. We're pretty busy though. This is my wife. She's an OB/GYN. In addition to doing the work of orthopedic surgery, being at Rothman, we're pretty involved in academics. So I do presentations, teaching. I have residents and fellows that work with me. I'm the associate program director of our residency program. And then probably most important on top of that, we have these two girls that keep us busy with all of their antics and activities. So that's kind of the more fun part of everything. But to get into it with some topics about shoulder surgery. So as I mentioned, a lot of these talks will be about shoulder pain. Why do I have shoulder pain? What's the problem? What do you do for it? Certainly very important topics. I've given a good number of those in the past. We talk about different treatment options, non-surgical, surgical, all of those sorts of different things. But not as much gets focused on in the recovery, or if it is, it's about very specific surgeries of themselves. So I just wanted to spend some time about what recovery timelines are like, why they are the way that they are, kind of general broad topics about what sorts of things we're doing when we're treating different shoulder pathology. So the big question is, why would you have surgery? Orthopedic surgery, obviously, for the large part, is elective. There are some things that are a little less, though, fractures and other things like that. But for the most part, it's not life-saving surgery, as I'll get into a little bit more. So there's always a discussion and there's always a reason as to why you have surgery. A lot of times people come in with MRIs where they have torn tendons, or they, have a radiologist report that says, oh, a lot of this scary stuff, and they think that's not everything needs to be fixed to it. And the truth is that what I always tell patients is we treat the patient and not the MRI or not the imaging study. So there are things that we need to focus on you and what you're feeling, and if surgery is the right answer for those problems. So really the two main buckets that I focus on when we're thinking about potential surgical management for a problem of the shoulder is, what is your function and what's your pain? And those are really the two main symptoms, really in all of orthopedics, and specifically for what I do with shoulder and elbow surgery, to determine if it's something that we can fix with an operation. So what do I mean when I say function? So it's a pretty broad term. I think people interpret it differently. What I mean when I say it is a combination of your range of motion and your strength. So basically, how you can move your arm around in space, how you can do the things or can't do the things that you need to be able to do with your arm. So reaching up to a shelf to grab an object, lifting something overhead, lifting weights, lifting up a child, all these different things that you do with your arm. Even less functional things, maybe like just bringing your hand to your mouth to wash your face, brush your teeth, eat food. It's all different. Everyone has a different functional span or functional goal of what they need to be able to do. And obviously, it's all dependent on where we are in our life, what sorts of things we want to be able to do, and what sorts of things we can do. So, when I meet you in the office, that's something I'm trying to get an idea of in talking to you is what your normal functional status is, or what your current functional status is due to your injury, and what you want it to be. Um, and then pain. Pain I think is easy for each person to know what it means, but it's really hard for you to tell someone else what pain means, just as it's really hard for someone else to tell you what your pain or their pain is. It is the most subjective finding that we have to monitor. There used to be this campaign 20, 30 years ago called Pain is the Fifth Vital Sign, which has gotten a lot of scrutiny recently because of how it led to kind of the overprescription of opioids. However, the point being that it's something that's always asked. Anytime you go into a doctor's office, anytime you go to a hospital, if you're having any sort of pain, you're always going to get that, what's your pain, 0 to 10, right? That's a very, it's unfortunately kind of the best that we have, but it's very subjective, meaning it's unique to you and how you experience pain. And you get people, people will say that they have a high pain tolerance, they experience pain differently, and that could all very well be true. So it's all uh, something we have to try and work through and figure out as to the pain that you're feeling. Where is that compared to the normal amount of pain that you have or discomfort that you have, and how this new problem is affecting that. So different pathologies that I treat in the shoulder, these are kind of large bucket items. Arthritis is one of the most common. Arthritis is a disease of the cartilage. So when you talk about a joint is where two bones meet together and move around. So the shoulder is a joint. The main two bones involved with it, excuse me, are your humerus and your scapula. So humerus is your arm bone, scapula is the shoulder blade, and the shoulder blade has the socket part of the ball and socket on it, and the humerus has the ball part of the ball and socket. And on the end of those bones is a structure called cartilage, which is basically like a cushion of the joint that allows the joint to move around smoothly in a pain-free fashion. Arthritis is a disease of that cartilage where it starts to thin out and the bone underneath starts to rub on the bone on the other side, and then it doesn't move as smoothly and it causes pain. Soft tissue injuries are also something I manage very commonly, the rotator cuff being the most common. The rotator cuff is actually a group of muscles that connects that shoulder joint and goes from the scapula, the shoulder blade, to the humerus or the ball. And it's made of four muscles that surround the whole joint and help to keep it stable. And it's really the tendon part of that muscle when the tendon can tear off the bone where issues become are prominent. The labral tears are another issue. The labrum is a structure that surrounds the socket and makes the socket deeper and allows the ball to sit stably in the socket. Labral injuries usually occur as a result of a dislocation of the shoulder. So when the ball comes out of the socket, and the labrum will tear. And then ligament tears. Ligaments are another structure that helps to keep the shoulder stable. As opposed to muscles, which are a dynamic structure that can move, ligaments are static, meaning they're at a fixed length, and they again span joints and help to keep joints together. So dislocations again can lead to ligament injuries and labral tears. And then fractures are another large part of what I treat as well. A fracture is when a bone breaks. A very common question or statement that people say is, I broke a bone, I didn't fracture it. It's essentially the same thing. I think people have a different view in their mind of what fracture means. Maybe that the bone breaks into many pieces, or that there's just kind of like a crack through the bone as opposed to a break. But it's all, in a sense, the same thing to us in that the bone, the outer part of the bone, has broken and either stays in the same position or shifts, and that kind of depends on how we treat it. So those are reasons why to have surgery, but what do you do before you even get to that point? And these are, again, common generalized options that we do for these different pathologies. Modifying activities is always the first thing you can do. And quite honestly, by the time that somebody comes in to see me or one of my partners in the office, it's something that you've already done. It's a natural reaction to a joint or an arm or a body part that just isn't working normally. You naturally brace it or just don't do the things that make it hurt. And that's what we mean by activity modifications. And so the question is, can those modifications or are those modifications things that you can live with, that you can adjust your life so that if you can't reach the arm straight up overhead, but you can get it to about here, is that something you can live with and just know that maybe the shoulder or whatever it might be won't go to its normal function before, but that's okay. Physical therapy can be an option to help treat, again, this pain or limited function. And what a therapist is going to do is not only help to do things like stretch or give you strengthening exercises to work on, but therapists are really focused on the position that your body is in while you're doing exercises and how you're strengthening different muscles and what muscles you're working while you're strengthening them. And I think that can be really helpful. There's only a limited amount of time that you have when you come to see a surgeon like myself in the office, depending on what we're talking about. Usually the visit's 15, 20 minutes, maybe 30 minutes if it's something a little more complex. But it's difficult to take the time for me to really go through how you're doing exercises and the position that your body and your shoulder is in while you're doing different strengthening or lifting exercises. And that's where a therapist can be really helpful. You're in a big space in a gym. They have a lot of exercise equipment there. They have mirrors so you can see how what form you're doing, the position you're in when you're doing these exercises. So, it's not an uncommon thing for me to suggest physical therapy to patients. Unfortunately, it is a common thing for patients to roll their eyes at me and say that they don't think that they're going to get too much out of therapy, because I understand that some people don't have the best experiences with therapy all the time. But I think if done for the right reasons and with the right thought process, both from the patient and the therapist going into it and looking to achieve similar goals, that it can be something that can be very useful. Uh, Outside of that, a home exercise program is another option if somebody is very adept at doing different exercises, and we can kind of go over some exercises quickly in the office and they feel comfortable doing that at home. That's certainly another option as well. And a lot of these help with the symptoms of pain and limited function because it might be that there is a muscular imbalance, especially in the shoulder. The shoulder is a very dynamic joint, meaning there's a lot of different motion to it. So it's not just that ball and socket joint, because the shoulder blade or the scapula is not as firmly fixed to the central skeleton as, say, your pelvis, where your hip is, which makes the hip a very stable joint, but also really limits the amount of motion that you have at your hip. The shoulder has so much range of motion because the shoulder blade or the scapula can move so much around the rib cage or the thorax, giving your arm and your shoulder so much range of motion. Because of that, however, you can also get a lot of imbalance of all those different muscles that attach to the shoulder blade, and that can cause problems with pain, discomfort in the shoulder, and dysfunction too. So that's kind of managing a lot of the functional deficits, which can, in large part, also manage the pain that people experience in the shoulder. And then there are other options just to purely manage pain. Obviously, there are medications that help with this, like Advil, Tylenol, Aleve. I know that a lot of people don't like to take medications a lot of times. I do hear that. I myself, take Advil not infrequently if there's little aches and pains. It's a really helpful medication. Advil and Aleve are a group of medications called non-steroidal anti-inflammatories. So, and just as the name says, they're not steroids. but they work to decrease inflammation in in the body. And then Tylenol is just a pain reliever. Um, it's called acetaminophen is the generic name. Not tr Actually, it's interesting. There's the mechanism of action, so how that drug actually works is a little bit of curious, but uh, we don't totally know, but we know that it does help block pain receptors in the body in a different way that an opioid does. So that can even the combination of those can be helpful for managing a more acute pain sort of setting, like a fracture or an acute injury. Cortisone injections are things that we can do in the office. So cortisone is a steroid. So as opposed to Advil and Aleve as non-steroid anti-inflammatories, cortisone is a steroidal anti-inflammatory. And steroids help to basically block the inflammation pathway that causes pain in the body. And many times it can be a chronic type of pain that causes that. So if you inject steroid into a space such as the shoulder joint, or on top of the shoulder joint, there is a space where the rotator cuff sits that can help decrease inflammation that causes pain. And there are many other alternative pain strategies that we can obviously refer you to. Other things that are new and interesting, medical marijuana and things like that, that are better for more chronic pain issues, but are always options to avoid an operation if needed. So, you've gone through all of that and you've had those discussions. So then the question becomes, do you really have to have surgery? And as I alluded to earlier, in orthopedics, the answer is in general, no, you never have to have surgery. It's not a life-saving surgery in large part, but it can be a life-altering. And for certain operations, it can be significantly life-altering. So if you have a really badly broken bone, or especially in your lower extremity, a broken bone around the hip joint where you can't walk, and you might never be able to walk again if it's not fixed, then yeah, those are things that while we say they're not required, they're certainly significantly life altering, and they can be life saving because if you have an injury that significantly affects how mobile you are and how you get around in life, can be other complications that occur from that. But when we're talking about shoulder and elbow surgery, the stakes are usually a little lower. A lot of people can live without a functional arm or an arm that can go straight up overhead, but it's a very inconvenient life to live, and sometimes a very painful life to live. And so those are reasons that, we would do an operation for your arm or your shoulder. And so when I meet you in the office, those are things that we discuss. What are the functional limitations? How much pain are you having from this injury or a pathology that you have? And what are your goals? What would you like to be able to do? And obviously, everyone's different. And so, it's my job, our job in meeting and discussing that to kind of figure out what works best for you and what our options are to give you those best outcomes as possible. So how does that get set up? So for an operation with me, what you would do is see me in an office. The office setting looks pretty similar to this. It would start with an office visit where I would talk to you and we would talk about the problem that you're coming in for, the pain, dysfunction that you're having, all these things that we discussed before, how they're affecting your day-to-day life. We'd review the history of that, what kind of treatment you've had to this point, where you're feeling the pain, and I take all of that information in and kind of assess what the likely problem is or what's causing the pain and dysfunction that you have, and combine that along with also performing a physical exam, meaning that I will move your shoulder around. I'll test the strength of your shoulder, which allows me to assess the function or integrity of the rotator cuff and the other muscles around the shoulder, as well as the muscles and everything that move your elbow and your hand, which gives me an assessment of how the nerve structures are working all the way down your arm, your sensation, and everything like that as well. And then review imaging. For most patients that I see for the first time in the office, we'll get an X-ray. And so that kind of basic imaging study will at least give me a beginning point to see, what's going on with the bones in your body. The X-rays, for the large in part, just show us the skeletal structures in the shoulder, um, and then determine if we need any more advanced imaging, such as an MRI or an ultrasound, or if we have enough just based on the the X-ray to to know what's going on, and then talk about different options. All right. So now you've decided you are going to have surgery. What's the next thing to do? So we schedule the surgery in the office. We, I talk about what the whole operation is, how it's going to, like what we're going to do, um, whether it's outpatient or inpatient. The large majority of operations that I do are outpatient, meaning that you leave the same day of the surgery. We have you sign consent forms in the office. So we talk about the risks of the surgery. The risks of the anesthesia are left more to discuss with the anesthesiologist on the day of surgery, but we do discuss that to some end, and you sign all of our consent forms in the office. And then you'll sit, I have a surgery scheduler who will go over things you need to do before the surgery, such as um, any preoperative clearance, like visiting with your primary doctor, getting lab work, EKGs, things like that. And everyone's different. It's largely based on your age and other medical diagnoses that you have. So then when we schedule a surgery, we talk about where it's going to be. Like I said, a majority are done outpatient. A lot of those I do at a surgery center, which is generally freestanding, so not attached to a hospital. Many of the surgery centers where we work, and one of the surgery centers where I work is right across the street from a hospital. But for the most part, you come into that building, you check in, you get set up, you meet the nurses who help take care of you, you meet the anesthesiologist. I come check you in for the operation. You go back into the operating room, which is this is what an operating room looks like. So you have these big lights in the ceiling that allow us to see clearly when we operate. We get a really focused bright light in the area where we're operating. You have these different machines around here. This is up here is the anesthesia machine. These are different machines that we use during the operation, whether it's an arthroscopy or not. There are different tools that we use that are electronic and otherwise. And then you would be laying on the operating room table. You get sterilely clean in the area we're going to operate and put drapes over everything to make it nice and sterile field. Most operations that I do take around an hour. On the longer side, some are 2 hours. There's always time beforehand and afterwards about going to sleep with the anesthesia and waking up afterwards. Many of the operations that I do, because it's in the upper extremity, the anesthesiologist does something called a nerve block, which means they put numbing medicine, like a long-acting lidocaine, basically, in and around the nerves that go down your arm. So there's a bundle of nerves called the brachial plexus that runs right inside the armpit. And they create all of the nerves that go down the arm that give function to the muscles down your arm and your forearm into your hand. And they can put this numbing medicine around there so that makes it so you don't feel anything in that arm. And you can't actually, a lot of times you can't move the arm afterwards. At a lot of the places I operate, we have a longer acting type of medicine that can last for a day to a day and a half, which is very helpful because it really helps for the worst amount of pain, which is generally or historically was in that first day or first night afterwards. And so if you can't really feel anything, your body doesn't experience pain, so you don't have to take as many, especially stronger pain medicines. So this is a very this this question I got very frequently, and it kind of was the genesis of giving this talk is what's the recovery, doc? So you had your surgery, how long you down for? When are you going to be back to work? When can you get back to playing golf, playing tennis, lifting weights, doing the things that you want to do? The short answer is it's complicated. Everyone's different. And we'll kind of go into some of the details of the different operations and some of the longer answers. Uh, the first part of the long answer is there's not really like a set time. It's kind of difficult. I'm a very literal person, so it's hard for me to always answer that like kind of directly in one sentence, because, as we'll get to at the end of this, a lot of the operations that I do in general, I say like 3 months is the recovery time, but that doesn't mean that you're wearing a sling like this guy for a full 3 months. That's like 3 months is the amount of time that you're kind of working through your recovery and working along that path to getting back to doing the things that you want to be able to do. So in general, for most operations that I do, the first 2 weeks afterwards are going to be very similar. They're pretty low key. You're just kind of letting the arm rest, um, letting things heal after the initial operation. For pretty much any operation within the shoulder itself, especially if you get a nerve block because you can't move the arm, you will go home with a sling on. And the sling is there to support your arm, especially if you have that nerve block, because otherwise the arm's just going to be hanging by your side. You literally have no control over it. And also, for whatever we did in there, we want to protect it. And we want to try and limit motion at the shoulder joint. So for a lot of operations, we'll get you set up with a sling like this. Has this pillow on it. Many of you have probably seen friends, family, people walking around with these on there. And the idea is it kind of extend. I'll show you my arm here. It extends your arm away from your body a little bit. So it takes a little pressure off of anything that we repaired there. So the arm's not all the way down by the side and kind of hanging down, and it kind of supports it a little bit more. That's the general theory. Um, so again, so you go home with that sling, you have the nerve block that really helps with a lot of the pain through that first night. And then I give you a prescription for pain medication. And as I said before, I'm really a big fan of non-steroidal anti-inflammatories. It can be a bit of a challenge because different people, if you're on a blood thinner or if you have issues with gastric ulcers and being able to take non-steroidal anti-inflammatories, it can be hard to kind of manage some things because they really are good at helping to limit the discomfort that people feel by decreasing that inflammatory pathway that creates the pain after surgery. There used to be some concern about taking NSAIDs and not having things heal appropriately, especially fractures or soft tissue repairs. But we've done a lot of studies in the last 10 or 15 years that have shown that they're not as detrimental to healing as was once thought. And they do a really, really good job of decreasing pain. So I'm a big fan of them. Since for the past probably 5 years in my practice, I've been using a lot more of these NSAIDs, especially a stronger type called Toradol for the first 5 days after surgery. And I've really noticed a decrease in the amount of narcotics that I need to give patients post-operatively, because that's been something that's been a huge focus of mine, is really to trying to decrease narcotics, because shoulder surgery in general has a very notorious or is very notorious, I should say, for being very painful and requiring a lot of narcotics. When I was in training, we would give a ton of narcotics to patients, which I don't think was a very good thing. And so I've really tried to steer clear of that. As far as showering and changing your clothes, usually within 2 days, depending on what we can do, you can take the sling off. You can let your arm just kind of rest by your side to be able to get in the shower, clean your body off, clean under your armpit. You can kind of let your arm hang away from you to do that. Get a fresh set of clothes on. I find that people always just have a better mental attitude, and therefore the recovery is going a lot better if you can get yourself, clean, dressed normally, and just kind of feeling a little more yourself. Um, but outside of that, we're really limiting the motion and activity of the shoulder and the arm, especially in those first 2 weeks. I'm going to take a minute to talk about sleeping. That's a big question, and it's a big problem, not problem, but issue that people deal with after shoulder surgery. And it's a real challenge because everyone's a little bit different. That's kind of my theme, I think, here. And everyone obviously can sleep a little bit better than other people. Um, by and large, people after shoulder surgery are more comfortable sleeping, sitting upright to some degree, whether it's in a recliner or whether it's using a wedge in your bed. The reason being, in my mind, is when we stand up, our shoulders hang from our body, like we said, and that's kind of the normal position the shoulder wants to be in, and it keeps the joint nice and neutral. When you lay back, the shoulder falls backwards, and it puts a lot of strain on the front of the shoulder here. Even when you lay on your side, it can kind of roll forward and put a lot of strain towards the back of the shoulder. So when you take gravity away from pulling your shoulders down, and your shoulder once it then starts to kind of shift forward and backward, it can be really hard to get the shoulder in a position that's comfortable, especially, excuse me, in that post-operative period where it's trying to heal. So this is a screenshot after I Googled, positioners for sleeping after shoulder surgery. There's all sorts of things that are out there. I think some things work better than others. Um, I've never seen this one before after until I just Googled it. It looks kind of interesting. I don't know how it would work. The shoulder sleeper. I've had the people that make that pitch me on it. And it's a little clunky to wear. I've recommended to some patients. I've had some mixed reviews. It's kind of one of the hard thing to say, like, yeah, you definitely need to spend $150 on this if it's not going to work real great for you. So, they might have a return policy. But obviously, there's all these different things that you can try and just keep the shoulder in a really immobilized and neutral position while you're healing. And quite honestly, it's a lot of trial and error. But I think the best thing is whether you're in a recliner or a wedge in your bed, a lot of support behind the shoulder blade, a lot of support behind the arm so that it stays in kind of a neutral position. By neutral, I mean kind of like in this position, not like back behind you or not way up in front of you like that. All right, so you've made it through your first 2 weeks. You're figuring out how to sleep. Now the real work begins. So um, I see pretty much everybody about 2 weeks after the surgery. I usually check in with patients initially, like the day or two after surgery too, especially if you've gone home. I generally give you a call, check in, make sure everything's going okay. I give everybody our direct number for our office, which goes directly to my clinical assistant. So he's always available to answer questions or issues that patients have. And then we see you back in the office at 2 weeks. Usually that's just to check your incision, make sure things are healing well. If you have any stitches in, we take them out at that time. And then the continued recovery from there really depends on what you had done. Basic goals, and we'll go into a few of the different operations after this. But if we didn't repair or fix anything, I'm not waiting for anything to heal. I'm not trying to protect anything. And you have very limited, you're allowed to pretty much do anything that you're comfortable doing. So that would be like if you had a stiff shoulder and they had to take out a scar tissue, it's called a capsular release. That for that operation, you'd actually would have started therapy already. If we do just like a bone resection, if people have arthritis in their AC joint, which is the small joint on top of your shoulder, and we just resect a little bit of bone from there to take the pressure off and open up the space, you can start doing a lot of activity right after that. So if I didn't have to repair tissue, fix a broken bone, or replace the joint, there's not a whole lot of healing required, and you can start doing things pretty quickly. If something requires bone healing, so bones heal together pretty well, a little more quickly than soft tissue, so like tendons healing to bone, we can get you moving a little more quickly. We can start some earlier passive range of motion. If we're waiting for soft tissue to heal, which is like a rotator cuff repair, then it's going to take a little longer. I want to still keep everything a little bit still and really allow that tendon to start to heal. So really quickly, a little primer on how tissues heal. So bone is a unique structure in that it can make itself and it can heal itself. So obviously, if you didn't break your bone when you were a kid or know have a kid that broke his or her bone, you know that you can put a cast on it and the bone will heal and almost look normal again. The way that works is when the bone breaks, it disrupts the blood vessels that are within the bone. They start to bleed and they create what's called a hematoma, which is this little collection of blood around the broken bone. That hematoma starts to reorganize into something we call a callus. So it's almost like a scab that you see on your skin, and those new blood vessels start to grow. When that starts to happen in that first couple of weeks, the bone gets what we kind of call sticky, meaning it's not full strength by any means, but it can start to move together again, even though there's not hard bone that's connecting it. That soft callus, we call that a soft callus, is enough to allow the bone to start to move. So a lot of times, even if we're treating a fracture without surgery, you can start to get the bone to move a little bit because one of the things we want to avoid is joints getting stiff. And then the bone really starts to heal well between 1 to 4 months. So we can then start putting some more pressure through it and start doing strengthening exercises when you're about 6 weeks out from an injury like that. And then, by 4 to 12 months, the bone's almost completely healed. Soft tissue, on the other hand, is different. So, like when we do a rotator cuff repair, we're asking for two different types of tissue, tendon and bone. Bone is a tissue, it's just a hard tissue, to heal together. And that's more challenging because it's not the same type of cells that are healing to one another. So this is a picture of, you have bone cells, which are called osteocytes, and then you have tendon cells called tenocytes. And then in between this structure we call the enthesis, it's that kind of joining together. You have chondrocytes at different stages of their cell life. And that's what creates where the tendon attaches to the bone. You can see that in this. This is like like a special type of microscope picture that shows that. And so it actually, for these strongest fibers of tendon to heal into the bone of the rotator cuff, for example, it takes 3 months. So we have to kind of really take the recovery a little more slow until those tendon fibers can really heal into the bone. All right, so I'm going to jump into and go over a couple surgeries here, so we can finish this up and then get to some questions if we have them. So shoulder replacement surgery, I do a lot of these every year. There's two different types of shoulder replacements. This can make for a confusing introduction, and I won't go too much into the weeds of that. That's kind of a whole nother hour long talk. But the basic reason is, as I mentioned before, the rotator cuff muscles help to create stability of the shoulder joint. And if you have a torn or a not well functioning rotator cuff, then you're not going to have a real stable shoulder joint. So if we were to do this type, which is called an anatomic replacement, that ball is not going to be real stable in the socket. It'll move around. It won't give you the strength back in the arm, and it can eventually lead to loosening of the implants. So that's why this reverse shoulder replacement was invented. As you can see, it's a much more stable construct. It doesn't require a rotator cuff to stay in that stable position. It uses your deltoid and your other bigger muscles around the shoulder to stay stable. When I do these operations, we have to get into the joint to take out the cartilage parts and replace them with these metal and plastic parts. And to do that, I do have to take off the front muscle of the rotator cuff, which is called the subscapularis. And that's something we do at the time of surgery. And then I repair it back at the end of the surgery. Having that repair heal is really vital for an anatomic shoulder replacement to work well. It's not as important in a reverse shoulder replacement, and many times the tendon is even more diseased because of the pathology for the reason that we're doing the reverse shoulder replacement. So because of that, my recovery between these two is going to be a little bit different. You can do passive range of motion after an anatomic shoulder replacement, but passive range of motion only for 6 weeks. And passive range of motion means that your other arm or a therapist or a family member is moving your shoulder around to keep it stretched and keep it mobile. But you're not doing any active motion, meaning the arm's not going to be moving under its own power. Once that 6 week point hits, that tendon will be well healed because I take it off with a piece of bone and I get that better bony healing that we talked about. And so by 6 weeks, that'll be well healed to where we can then start doing some more strengthening, allowing you to move the arm around. And then you work through about 6 weeks of building your strength back up. As with PT as needed, a lot of times people can do it at home to the point where at 3 months, the shoulder's functioning pretty well, with almost hopefully near normal range of motion and getting close to normal strength. With a reverse shoulder replacement, again, I'm not as limited in terms of your active motion. You can start that a little sooner, and then you can continue to advance that. And again, it takes about 3 months to kind of retrain those muscles too and get them working and functioning a little more normally. So rotator cuff repair, as I alluded to a little bit before, getting that tendon to heal to the bone is really key. So these are a couple pictures showing what those rotator cuff muscles look like. So this is the front muscle called the subscapularis, the top muscle is called the supraspinatus, the infraspinatus is in the back. And there's another one called the teres minor, which is never really, excuse me, too much of an issue during a rotator cuff tear. But this is an example of a rotator cuff tear. So where this tendon of that muscle tendon unit is pulled off of the bone where it normally attaches. And the way that we repair this is pretty much always arthroscopically. So we can go in with these small instruments and put these anchors in, which is what these little circles are. These are little plastic anchors. They look almost like wall anchors. They screw into your bone and they serve as the anchor site for these sutures. And then these sutures, we then pass through the tendon, tie them down. We can bring them out to even more anchors out on the side. and that repairs the tendon back down to the bone. I always tell people that's kind of temporarily holding the tendon onto the bone. Excuse me. And then through that process of tendon healing to bone, we just have to give it time to allow that to heal. So for the rotator cuff repair surgery, I generally describe in 3 6 week periods. So the first 6 weeks is the immobilization phase. So we're really just holding the shoulder still. I really don't want a whole lot of motion between at this humerus that would allow motion at that repair site and really allowing the tendon to start to get its initial healing fibers into the bone. We don't want to do that for too long though, or else the shoulder will get very stiff. So by 6 weeks, we can start doing some more passive motion without as much risk of disrupting this repair site, but we don't want to activate the muscles a whole lot. So we have you start physical therapy where the therapist is going to work on helping you stretch it out and start to get that motion back. And usually at the point where about 3 months, people can get close to full motion passively of the shoulder. So once you hit that 3 month point, then the tendon's going to be well healed to where we can then have you start doing more strengthening. Things are going to be weak from really not using the shoulder for that period of time. And so then we can have you advance the physical therapy to start working on more strengthening. Usually it's about another 6 weeks. Some people need a little bit more. It's a person by person basis. A labral repair. So as we said before, the labrum is this structure that goes around the socket and helps deepen it and serves an attachment point for the ligaments and provides stability of the shoulder joint. And when you get a tear in that after a dislocation, sometimes it does require repair to keep the shoulder stable. And what that looks like is passing these sutures around the labrum, and we have anchor points in the bone here, and that kind of sucks that labrum back down onto the bone to allow it to heal. Because this isn't as mobile of a structure as the rotator cuff, I can move patients along a little more quickly than after a rotator cuff repair. So it's generally 4 weeks in the sling and then beginning the passive motion for about a month and then the active motion for about a month. So the full recovery is about 3 months. And then fractures, as we said, fractures, bone heals much more reliably than soft tissue heals to bone. And they also tend to get quite stiff. So this is an example of what we call a proximal humerus fracture. So the humerus is the arm bone, and up at the part of it in the shoulder joint, it can fracture on these pieces, which are the attachment sites of the rotator cuff. And so if those are moved out of position a great deal, sometimes they do require surgical fixation to get them back in a better position to allow the rotator cuff and the shoulder to function more normally. And so when we do that, it's an operation where you go in and expose that part where the bone is fractured, line it back up, and then use these things we call plates, which kind of look like this. They can be made of stainless steel or titanium. You put them onto the bone and put screws in to stabilize the fracture and then allow it to heal. And again, because we're looking at bony healing, we can move you along a little more quickly and start range of motion a little earlier. A quick note on passive and active range of motion. I kind of mentioned this before, but again, passive meaning your muscles on that shoulder, that arm, are not being activated to move the joint. So that means you can do it on your own. You can lift your arm up with your other arm. You can use these things called a pulley, or you can have a physical therapist do it for you. But the idea is to really keep the muscles quiet in the joint while allowing the joint to move. Active motion is you're moving it under your own power. So you're raising the arm up. Your muscles are activating and kind of building the strength to get back to moving it, under your own power. So a lot of information. But in summary, and to generalize things, you have generally 4 to 6 weeks of keeping the shoulder still, with at the very least the first 2 weeks in a sling to just let any surgical repairs heal. Then we begin. So this is kind of my red zone. This is like a rotator cuff repair. The red zone is just like stop, not do a whole lot. And then you'll start passive range of motion, whether it's at 6 weeks for a rotator cuff repair or 2 weeks for a fracture. Again, it's very, depends what we do. But it's a little more the yellow zone. So we're going to allow you to move, but it's not going to be trying to move it around as much as you can. A lot of times pain will limit you from doing that anyway, but we want to try and build that range of motion back because that helps the pain go away too as the shoulder starts to get back to its more normal range of motion. And then once we hit that kind of 6 week point or 3 month point, then we can really start moving it more, being more active with it, and kind of building that strength back up. And so this is another graph I just made, where in general, how long's the recovery, doc? I mean, 3 months, like I said, for seeing me or going to physical therapy. Yeah, but the other thing I tell people is you're really making gains for a whole entire year after you recover from a shoulder surgery or an injury. Your biggest gains are in that 3 month point. You're going to have the steepest curve of improvement, but then it starts to slowly plateau over that time. And generally, when you're about a year out, you're mostly completely plateaued to where you're going to be, and hopefully that's back to normal function or at least where you want to be. So I hope that was helpful. Um, and hopefully it generated some questions. Looks like it did. All right. So I will start at the top here. Um, Dental work restrictions, preoperative and postoperatively. So if you didn't have a total shoulder, I'm not worried about it at all. You can do any sort of dental work that you need to do. The concern of dental work with orthopedic surgery is when you have a shoulder replacement. Um, the reason being is there was a theory, sometimes we do see it where, if you have a lot of deeper dental work, we have a lot of bacteria in our mouth just naturally. And if they're doing anything real deep in the gums or pulling teeth or different things like that, the bacteria that are in your mouth can get into your bloodstream. They go around your body. If you have, normally our healthy, normal immune system, we'll just take that bacteria out and get rid of it. It's not a big deal. The concern is if you have a joint replacement, that bacteria can find its way into the joint and seed the joint, and then create an infection. There's a lot of debate about this. There's been a lot of back and forth between our academy, the Academy of Orthopedic Surgeons, and the ADA, about what the right treatment is. And each person has their own personal kind of beliefs on it. But I would say that the general recommendations are that long-term antibiotic prophylaxis after shoulder replacement does not is not necessary. There's not enough evidence to suggest that it's going to make that big of a difference. Because the other side of it is taking antibiotics just kind of whenever is not benign either. So we try to avoid overusing antibiotics as well. So for me, um, generally I tell people for the first 3 months, if you can just avoid dental work, like if you're planning to have your shoulder replaced, don't plan to do any dental work for 3 months. And then after 3 months, no antibiotics are required and you can have dental work done as needed. All right. What is the recovery timeline from a shoulder ultrasound guided percutaneous tenotomy? So I don't do that procedure a lot. Yeah, usually, there are a couple brand names for that. One is 10X, one is 10 Jet. The idea is it's a needle that goes in that shoots kind of like a high flow fluid. It can be used to break up calcium deposits. It can be used for tendonitis. Um, I don't do it, so I couldn't tell you precisely, but there's probably not too much of a recovery time from it. We're not repairing anything, so you're not waiting for anything to heal. It's probably along the guidelines of kind of taking it easy for about 2 weeks, and then as your pain allows, getting into back into your normal activities. All right, recovery different for reverse versus conventional replacement. So, yeah, as I mentioned, with an anatomic and a reverse, an anatomic replacement for me, I'm gonna want to repair that subscapularis repair a little bit more. So it's passive motion only for 6 weeks, and then beginning active motion. And for reverse, you can start active motion at 2 weeks. What is the weight limit after a reverse shoulder surgery? I think this is a little debatable too. I honestly don't give people specific weight restrictions. Um, there used to be some guidelines, especially for, reverse shoulder. It's becoming much more commonplace and people are becoming much more comfortable with it. It's only been FDA approved in the United States for about 20 years now. And I say only because we've been doing hip replacements for the better part of, 60 years in the United States, maybe longer. Um, And so there was a lot of unknown, and I think we're learning more and we continue to learn more as we continue to do more of them. And so people did put a weight restriction because there was a concern of causing more traction and causing a dislocation. I find that people who get a reverse shoulder replacement, are probably not going to be lifting so much that it's an amount that I'm worried about it. There are rare exceptions of people who are, um, really heavy lifters or do certain things and for whatever reason need a reverse shoulder replacement, and we try to avoid at all costs of doing it if there is a high risk scenario for it. So I kind of tell people, for some things like lifting straight out, lifting overhead, there's really no restriction. But the more weight, the higher weight and repetitive amount that you do, the more you can wear out the parts. The plastic that's in there is no different than, like a brake pad in a car. It can wear out with time. And so it's kind of, there's no definitive number, but it's kind of being, using your best judgment. I do have an opinion on PRP after surgery to facilitate recovery. I think that the evidence is mixed on it. It comes at a cost that I don't think is substantiated by the limited evidence that we have for it at this time. The times that it's used after like rotator cuff surgery, for example, so you do this whole operation, you're doing it arthroscopically, which means you're pumping fluid through the shoulder to be able to see and do the repair. And then people take a needle or syringe and inject PRP. So PRP is something called platelet-rich plasma, which is your own blood that's drawn out. You put it in a centrifuge, so you spin out the red blood cells, and the part that's left is made up of your platelets and your plasma, which are healing factors for the body. And that definitely, in a lab can definitely enhance healing. However, I feel like if you just kind of our delivery mechanism is not that great, and where you're just kind of spraying this stuff on top of a repair you just performed. And I have trouble believing that it's actually getting in there and doing anything. We do know that for non-operative injections, there are benefits. It's shown to be a good anti-inflammatory, but as far as aiding healing and rotator cuff, the evidence just isn't there in my mind. When in a sling, how do you put a shirt or robe on safely? It's a really good question. Sorry, I didn't go over that. What you do is you basically let your arm hang by your side. And then while your arm is hanging by your side, it's kind of hard for me to show seated down, you slide shirts or sleeves on that arm first, letting your arm go by your side. And then since your other arm's a little more mobile, once you slide it on, you kind of pull the shirt or whatever it is around and then grab it from the other side and pull your better arm back through it. So the key is to put the bad arm in first, so you're not having to move it around as much. If you try and put the bad arm in second, you're going to have to move it way more than you want to. Are bone spurs considered arthritis? Bone spurs, obviously, is a generalized term. We call them osteophytes, and they can be a byproduct of arthritis, especially in glenohumeral arthritis, and osteoarthritis, which is kind of the most common type of arthritis. Um, as the cartilage wears down and the bones kind of deform, your body will make this extra bone, what shows up as these bone spurs. We think it's trying to increase the surface area of the joint. Essentially, your body's trying to kind of do something to fix a problem that it has. They are managed in the management of arthritis, which is a shoulder replacement. We remove all of those bone spurs. There are other areas where people can get bone spurs, such as like on your heel, or other things like that, and that's a little bit different. Those are something we call traction osteophytes. But yes, bone spurs can be a part of arthritis. All right. Therapy for reverse shoulder replacement, weight training for upper body. I've had 5 surgeries for rotator cuff. The fifth was a reverse shoulder replacement in 2020. Um, so as I mentioned, a lot of, you can start active motion pretty early. Anytime you're recovering from surgery, especially if you've had a lot of surgeries, you want to start low and be progressive. So I always tell people, once you start that active motion, you want to start doing, like, whether it's therabands or really light weights, activities where you can do, 10 or 15 reps of a certain exercise where the last rep is just as easy as the first so that you're not kind of overworking the muscles. I think that that's always key, and you kind of build your way back up from there. I have grade 4 osteoarthritis in my left shoulder. Pain is about a 3 to 4. I've tried PRP, it didn't help. I also had a shoulder arthroscopy about a year ago. The outcome was minimal improvement. What are your thoughts on exosomes as an additional regenerative medicine therapy? Unfortunately, I am just not very read up on exosomes, so I wouldn't be able to speak fully about that. I apologize. I had a displaced bone and complete rotator tear, screwed and anchored, had to wait a month for surgery. PT now 4 weeks, muscle still tight. What is the timeline for a complete heal and 100% range of motion and strength? Um, so as I said, I mean, if you're kind of 4 weeks into physical therapy, it's going to be normal to still be stiff. I usually don't expect patients to get close to full range of motion until about 3 months afterwards, and 100% range motion and strength in my, minimum time period for me is usually about 4.5 months. It can be even longer. I need a physical or need a shoulder replacement. If physically doable, what pre-surgery PT strengthening would be helpful? Um, you know, I don't tend to advise physical therapy um, as a real treatment for arthritis or before a shoulder replacement if people have bad arthritis because it generally, excuse me, just creates more pain. The bones are just grinding on one another, and if you have a therapist just kind of cranking it around, it can just make it more painful. My recommendation I always give is just trying to keep the joint as mobile as you can. If you can do some sort of deltoid strengthening, that can be helpful. It can be more painful though. So, you really have to balance. It's a fine line of balancing enough motion and exercise and strength to not overdo it and create too much pain. So it's kind of an individual basis for that. What complications have you seen from a posterior shoulder replacement? How do these complications impact recovery timelines and ADL? Example, if needed, understand I can't get the specific scapula fracture after a posterior shoulder replacement. Posterior shoulder replacement, um, I'd have to just talk to you more about that if you mean the approach, which is, normally we do a shoulder replacement through an anterior approach. Um, there have been some studies about trying to do it through a posterior approach so as not to take down the rotator cuff, but those are very limited. And I know from the studies that have been published, they've had not as good outcomes as we normally get from our anterior approach. So I'd have to, that's a little more specific, unfortunately. Um, I have the Inspire sleep simulator. Will this impact my surgical experience? I don't believe so. I can't say that I've run across a lot of people with that. I do know that it can impact you not being able to get an MRI. But I don't believe like going through anesthesia or anything like that, it would be an issue. But that would be a question more for the anesthesiologist, to be honest. Use ice after shoulder replacement. Yes, ice can definitely always be helpful. People always ask about the ice machine. I'm not a huge fan of it. Some people think they work better than others. I've tried them on myself. I find that they're a little clunky. They work really great on limbs where you can get full compression. So your knee, your ankle, your elbow. But it's really hard to get full circumferential compression with those ice machines. But I think so they're just a bag of ice on there is just as good. Under the shoulder replacements, how much time will we be out of work? Also, if the shoulder's replaced, can we return to playing tennis, golf, and light weight training without limitations? It really depends on what you do for work. If you're doing a desk job or something like that, I generally tell people to plan for about 2 weeks just to kind of through that first period where you can have more of that immediate post-operative pain. Some people are able to get back within a week. That's a little bit different. And then as far as golf, tennis, and light lifting, absolutely. That's kind of the goal a lot of times for people who have that surgery. When it comes to fitness, is cardiovascular exercise like walking okay during recovery? Absolutely. I tell people anything lower extremity is great as long as you're not being too strenuous with the arm or anything. But yes, definitely walking or, if it's too cold outside, getting on an elliptical or stationary bike, that is definitely okay to do. Does repair does surgery to repair an AC joint separation fall into line with the fracture recovery timeline? It actually falls a little more in line with a rotator cuff because the AC joint, we're actually waiting for ligaments to heal when you do an AC joint reconstruction, because it's the injury is based on actually ligaments tearing. So it's a little more in line with a rotator cuff recovery. Can you regain full range of motion with a shoulder replacement? With an anatomic replacement, yes, the goal is full range of motion like a normal shoulder. A reverse shoulder replacement will have limited range of motion, just based on the fact that it's slightly more constrained implant. So in general, people can't always get straight up overhead, but they can get about like this. And then behind the back after a reverse replacement is unfortunately extremely variable. Some people can get pretty far behind their back. I would say on average, people can get to about their back pocket. When you have a reverse shoulder replacement but need rotator cuff repair, is the same recovery as a reverse shoulder replacement. Um, we usually do a reverse shoulder replacement because a patient has a non-repairable rotator cuff. So we're generally not repairing the rotator cuff at the time of doing a reverse replacement. And so that drives more of the recovery. Had surgery in the beginning of November, still having pain at terminal points. And in the morning, any advice other than continuing PT and stretching? Um, so 4 months, um, that certainly still can be normal to have some stiffness and pain with that. So, obviously very, very much depends on what you had done and what things are looking like at this point. Any limit for surgery is 80 too old? No. I think that age, honestly is a number. It's largely dependent on how active you are. I've seen extraordinarily active 85-year-olds and I've seen very sedentary 55-year-olds. So it really depends on what you want to be able to do and how much it's affecting your life and what you want to be able to get back to. If I require shoulder surgery, why would I have an anatomic or reverse? Reverse seems more effective and a little easier to recover. It's really a range of motion issue and getting the shoulder almost nearly back to normal. Um, and also anatom or reverse is kind of a very definitive. You can't kind of go back to an anatomic afterwards, but it's a good question. Um, how do you address calcific tendonitis in the rotator cuff? As one of the first people asked, I actually a lot of times send them to one of my non-operative partners to do that procedure where they can go in and kind of blast apart the calcific tendonitis. I used to do surgery on it a little more regularly, and then you end up having to you end up destroying a little bit of the rotator cuff when you take it out arthroscopically and then have to do a repair, and then the recovery is longer. And we've found people have had pretty good success with that less invasive approach. Um, how does it work when you have a complete shoulder implant? Does the operative site go down to the elbow? No, the incision's actually only about 4 or 5 inches long. It's right in the front of the shoulder. It's spread between the deltoid and the pectoralis muscle. And a lot of people heal very well in that area where you can hardly even see the incision. Some people get keloids or heal a little bit differently. But if it's a stemmed implant, it's usually only a few inches long, so it really doesn't go that far down the arm. Um, is 1 month okay for sling use after a tear or bone repair? I was told a month to start passive and not use a sling anymore. It can be, at a month, I do have people start a little bit of range of motion at home. I generally wait 6 weeks for formal PT. Every surgeon's a little bit different. It's all depending on, what their thought process is, where they trained and things like that. I need a total shoulder replacement. I'm 74. Osteopenia. What is the percentage of fractures that occur in the shoulder blade after this procedure? That's a little variable. It's reported between 1% and like 10%. I would think in my hands, it's on the lower end of that. It's closer to 1%. Um, it is a concern, something we would discuss, but it's a low percent chance that it does happen. If you're diabetic, can you still have surgery? Yes, although your diabetes needs to be well controlled, and usually our kind of guideline for that is a hemoglobin A1C of less than 8. The higher it is, you run the risk of getting stiff after surgery if your diabetes is out of control, or it kind of runs on the higher end. And it can also increase the risk of infection. You have pain in the forearm, waiting on reverse revision, how to help with burning pain in the forearm while waiting. There are medications that can help with that, but I'd recommend speaking to the doctor who you're working with. Tomorrow will be 1 year since my shoulder replacement, thanks to pickleball. Must I exercise for the rest of my life? Still pretty sore on extreme reaches. Sometimes it depends what type of shoulder replacement it is, how the range of motion is coming back. It could still cause a little discomfort at those extremes. I think just continuing to be active with it is never a bad thing. For shoulder replacement after initial recovery, do you recommend any weightlifting limits to mitigate wear and tear? I did kind of touch on this a little earlier. Is a biceps reattachment recovery time similar to a rotator cuff? No, it's definitely a little shorter. Um, Usually you can start, I have people start active motion, or sorry, passive motion in 2 weeks and active motion by 6 weeks because generally it kind of heals into the soft tissue. Um, Discuss acromion necrosis, femoral head related to steroid injections. I think it means avascular necrosis, and that would be of the humeral head. Steroid injections themselves, because they're relatively localized, I think have a low risk of creating avascular necrosis, which is where the blood supply to the head is lost. Um, Systemic steroids can certainly be a risk factor for that, but it's not as much with injections. All right, maybe one or two more here. I'm getting a hemiarthroplasty. Is it's like the two shoulder replacements you described? It's probably more like the anatomic. It could be slightly more painful because you have the metal ball that's rubbing on your own native socket. And it also depends if they're planning to ream or recorrect the angle of your socket. That can be a little more difficult to recover from just from a pain standpoint. Um, all right. I think we're kind of running out of time here, unfortunately,
Yes.
but these are really good questions. I appreciate all of the interest. Thank you.
Yes, I did write in the chat box. We apologize if Dr. Davis was not able to get to everyone's questions. We did have a lot come in, so I think he did a great job at answering most of them. We did record this, so I will be sending it out to everyone who joined this evening and then everyone who did register but was not able to join. So thanks again, everyone, for joining us this evening. Thanks so much, Dr. Davis. You have a great presentation, very informative, and thanks for answering all the questions.
Yep. Thank you. Thanks, everybody.
Everyone have a great night.